We are discussing the cardiac output. What is the cardiac output? Simply speaking, this is the amount of blood that we're going to be pumping out of the ventricle in 1 minute. So I will be checking what is the amount of blood that I will be pumping per 1 minute from each of the ventricles, and this is going to be considered my cardiac output. So how do you think you will know the amount of blood that we pump in 1 minute? So if this is my heart on here, like this is my, let's say, left ventricle, I will be checking the amount of blood that we're going to be pumping per beat. So from one single cardiac contraction, we're going to be pumping a certain amount of blood. And I will multiply this by how many beats per minute. So the amount of blood that will be pumped in one beat, this is what we call stroke volume. So how do we calculate the cardiac output? Again, what is cardiac output? This is the amount of blood pumped from each of the ventricles per 1 minute. How would I calculate this? It's going to be stroke volume, amount of blood that I will pump per a single beat, times my heart rate. What is the heart rate? How many beats per minute? So 1 beat, this is the amount of blood pumped in 1 beat, stroke volume. Heart rate is how many beats do I have per 1 minute. And from both stroke volume and heart rate, you're going to be able to figure out the amount of blood that you pump from the ventricle in a complete minute. This is your cardiac output. So moving on to our next question. What is your resting cardiac output? The cardiac output at rest. It's about 5 liters per minute. So your heart is pumping out 5 liters of blood per minute while you're sitting down doing nothing. But if you exercise, if you are running, for example, your muscles will need a much higher blood supply, and this cardiac output will reach 4 to 5 times the resting cardiac output. So it will increase to be around 25 liters to be pumped per minute. In athletes, this can go up to 35 liters per minute to be pumped from the heart. The difference between the resting cardiac output and the maximal cardiac output, this is what we call the cardiac reserve. So this is the amount of blood that I can pump with my heart, but I don't pump it during rest. So my heart can pump maximally, let's say 25 liters. And at rest, what it's actually pumping is just 5 liters. So what is my reserve that I don't use? I keep it as a reserve. I have 20 liters of blood that I can pump, but actually I am not pumping. All right. So again, what is cardiac output? This is the amount of blood that you pump per 1 minute. What is the stroke volume? Stroke volume is the amount of blood that you pump in a single beat, 1 ventricular contraction. Maximal cardiac output is 4 to 5 times the resting cardiac output. And what is the cardiac reserve? This is the maximal cardiac output minus the resting cardiac output. The difference between those two is going to be considered my cardiac reserve. How do you think you're going to be able to calculate the amount of blood that you're going to be pumping per beat? In a single beat, how would I figure out the amount of blood that I will be pumping? Let's check on here. This is my ventricle, like this. And the blood inside my ventricle is the amount of blood that will be pumped. So what do we call the amount of blood that we pump in a single beat? This is my stroke volume. Stroke volume. So how do you think you will be able to calculate stroke volume? Do I insert a cannula, for example, in my artery to calculate the amount of blood that passes in a single beat? Actually, it won't be practical. So how I can identify and calculate the amount of blood that we pump per beat is simply by checking out the amount of blood, the volume of the heart at the time of the relaxation. This is what we call the end diastolic volume. So what is the volume that I have in here in my heart? The heart has two different parts. It has the volume of the wall of the ventricle, as well as the volume of the blood inside. So you have two things at the end of the relaxation. One, you are fully relaxed. You are filled with blood. So the end diastolic volume is simply the volume of the heart with the blood. This is my end diastolic volume. And I will be checking out the end systolic volume. What is the end systolic volume? This is the volume of the heart at the end of ventricular contraction. So once my ventricle contracts, ejects the blood out, what's remaining here is just the wall of the ventricle without any blood inside. You don't have any blood in here. When you check the end systolic volume and the end diastolic volume, you will be able to figure out the amount of blood that you've pumped per minute. How would I figure out this? By echo. So you're gonna get an ultrasound. The ultrasound will allow you to check the size of the heart. Checking the size of the heart in here at the end of the relaxation. This is simply heart plus blood. At the end of contraction, after I eject the blood to the outside, this is just the volume of the heart. By subtracting end diastolic minus end systolic volume, I will be able to figure out the amount of blood that will be ejected in one beat. Again, what do we call the amount of blood that we eject in a single cardiac contraction? This is going to be my stroke volume. All right? So again, what we've mentioned so far. What is the cardiac output? Cardiac output is the amount of blood that we pump in a single beat, in a single minute. This is going to be equal to the stroke volume, which is the amount of blood that I pump per beat, times my heart rate. How many beats per minute? How do I figure out the stroke volume, the amount that I'm pumping out of my ventricle in a single beat, in a single cardiac contraction? I will be checking out the end diastolic volume and the end systolic volume. Why would I check those two volumes of the heart with blood and without blood? The difference between those two volumes is going to be the volume of the blood that's going to be pumped in the ventricular contraction. Right? So what are the different factors here that will affect the amount of blood that I am pumping per beat? We have three major factors, and those are highly important factors. Lots of medications will be regulating the blood pressure through those factors. Lots of cardiac diseases will be affecting those three factors. So let's check the first factor on here that affects my stroke volume. So this is going to be my preload. What's preload? This is the amount of stretch that will be applied on the heart before the contraction. Or simply speaking, my venous return. The amount of blood that returns back to my heart. This is my preload, the amount of blood I am receiving. Like any elastic band, when you stretch it, you're gonna have a stronger force of recoil. Same concept on here. When I increase the venous return, when I increase the amount of blood coming back to my heart, I am applying more stretch. And the more you stretch the muscle, the stronger it contracts, like any elastic band. The more stretch, the more recoil force that will be created. So you see on here, first factor that we're looking at is preload. And this is going to be determined by the amount of blood returning back to my heart, which is my venous return. So what do you think? Which factor are you affecting? Are you affecting end diastolic volume or end systolic volume? If I'm telling you that you're getting more blood to your heart, so the volume at the end of relaxation and diastolic will be increased. If I'm getting more blood back to the heart, so more stretch is going to be applied, more expansion, because if you remember, you refill when you relax. So at the end of the relaxation phase, you're going to be having a higher end diastolic volume if you did have an increase in your venous return. So when you increase the preload, this will directly increase your end diastolic volume. Once end diastolic volume has been increased, what's going to be the effect here on my stroke volume? What do you think? Let's do numbers on here. So if, let's say, I have stroke volume of 5, and this was because end diastolic volume is 10 and the end systolic volume is 5. So 10 minus 5 is going to be 5. What if I told you that this 10 here, because you're getting more blood back to the heart, more venous return, it's going to go up from 10 to become 15. So now it's 15 minus 5, so it's going to be equal to 10. So you see on here, what happened to your stroke volume when you increase the end diastolic volume? Once you increase the end diastolic volume, this will directly increase your stroke volume. So the first factor here that is affecting the amount of blood that is pumped from the heart per beat, stroke volume, this is going to be my preload. The more blood that returns back to the heart, the higher the end diastolic volume, and the higher the end diastolic volume, the higher the stroke volume. Any questions so far? Questions? No? No? Our second factor here that will affect the cardiac output and the stroke volume is going to be my contractility. If this is my ventricle like this, it's filled with blood. This is my end diastolic volume. The volume of the heart at the end of the relaxation. It's filled with blood. What if I told you that I did have an increase in the force of contraction? What is contractility? This is simply how strong you're squeezing your ventricles. Increased in the force by which you are contracting. So the more you squeeze the cardiac muscle cells, what do you think is going to happen to the end, the systolic volume? If I did increase the force of contraction, I did squeeze my cardiac muscle cells, would I have a reduction or an increase in the end systolic, the volume of the heart at the end of contraction? If you squeeze, you squeeze, you squeeze, what happens to the volume? It decreases, right? So if you increase the force of contraction of the heart, this reduces your end systolic volume. So what's going to happen as a result in terms of stroke volume? Stroke volume again is going to be end diastolic volume minus end systolic volume. If I did have a reduction in my end systolic volume, what's going to happen? Let's say in here, let's do numbers to have a better imagination. So 5 equals 10 minus 5. So this 5 drops to become 0. So now it's 10 minus 0, so it's going to be 10. So you see on here, what's going to happen when you reduce the end systolic volume? Stroke volume will increase. And why did I have a reduction in the end systolic volume? Because I did increase the force of contraction of the cardiac muscle cells. And this is one of the things that will be affected by the sympathetic activation. So in a fight or flight situation, what happens? Your sympathetic nervous system sends more signals to the SA node. SA nodes start to work faster, increasing the heart rate and the force of contraction. So you see on here, when you increase the force of contraction, when you increase contractility, you're going to have a reduction in end systolic volume. Once you reduce the end systolic volume, you're going to have an increase in stroke volume, amount of blood that I pump per beat. Another factors that we're looking at in here is that will be affecting my stroke volume. This is going to be my afterload. What is afterload? By definition, afterload is simply the amount of pressure that I need to overcome in order to pump the blood. Or simply speaking, the amount of pressure that I will be facing getting out of the heart. This is what pressure on here. So if this is my left ventricle, this is my left ventricle on here. This is my blood that I'm pumping. This blood is gonna need to be ejected into the aorta, right? In order for the blood to move, it needs to move from high pressure to low pressure. Where is the low pressure should be? It should be in my aorta. Where should be my high pressure? This is low pressure on here. It should be in my ventricle. This is my high pressure. And according to the difference in the pressure, the blood is going to be moving from high to low pressure. What if I did increase this pressure on here, like this? In order for me to have the same pressure difference to allow the same amount of blood to be pumped out, what should I do? I should increase the contractility response. I should increase the force of contraction. I should increase anything that will allow me to maintain the same amount of blood. So what make me increase the force of contraction is the amount of pressure that I need to overcome, because the blood will never move from between two sides with equal pressures. So if a person has hypertension, for example, if I have hypertension on here, I have high arterial blood pressure. The pressure of the blood in my arteries is high. So what do you think is going to happen? In order for your heart to keep pumping the same amount of blood, how will it be responding? Remember, what is cardiac output? Cardiac output is the amount of blood that we pump in 1 minute, which is equal to stroke volume, amount of blood pumped per beat, times my heart rate. So what happens to the stroke volume in case of hypertension if I did have an increase in the afterload? I contracted my heart. The heart, after contraction, still gonna have some blood. Not all the blood was able to get out because of the hypertension, because I have high pressures that I need to overcome. Increased afterload. So what happens to the end systolic volume in case of high afterload? In case of high afterload, the end systolic volume is going to be increased. Why is it going to be increased? Simply because you're going to fail to pump certain amount of blood out of your ventricle. Some blood is going to remain in your ventricle. Why some blood will remain in your ventricle? Because simply you didn't get the same pressure difference that you need to pump the amount of the blood that you want. So what happens to the stroke volume in this case? If I did have increase in the end systolic volume, you see on here, let's do our numbers, 5, 10, minus 5. If I did have an increase in my end systolic volume, so rather than being 5, let's say it's going to become 10. So 10 minus 10, what happens to my stroke volume is going to be 0, right? I have a reduction in the stroke volume. So once you increase afterload amount of pressure that I need to overcome, less blood will be ejected per beat. And less blood ejected per beat, this means increased end systolic volume. An increase in the end systolic volume will cause a reduction in my stroke volume, the amount of blood that I pump per beat. So what happens if you did reduce stroke volume? What happens to the amount of blood that you pump per minute, cardiac output? So let's do numbers again. Let's say my cardiac output, let's see, it's 20, which is 5 times 4. All right, so stroke volume, let's say it's gonna drop to be 4 on here. I have a drop in my stroke volume because of increased afterload. So what do you think should happen to my heart rate in order to compensate if I want to maintain cardiac output at 20? So now it's going to be 4. It should be multiplied by how much to become 20? 5, right? Do you get this? So you have reduction in stroke volume. In order to compensate this reduction in the stroke volume, I needed to increase the heart rate. So one of the very early signs of hypertension, the patient will go to the hospital or to the clinic and he will be telling his physician, I feel my heart rate, I have palpitation. Why patients with hypertension will feel their heartbeats simply because they have tachycardia. They have fast heart rate. And this fast heart rate is simply just to compensate for the reduction in my stroke volume. I have reduction in stroke volume, but I want to maintain the cardiac output the same. So a reduction in stroke volume needs to be accompanied by an increase in the heart rate. That's why patients with hypertension will have palpitation, will have tachycardia. All right, so let's read this part here from your notes. So again, what's preload? Preload before my heart. So what is the preload? This is the amount of blood that can get back to my ventricle, or in other words, my venous return. So for example, a medication that will be reducing blood pressure, it's gonna be reducing venous return. And when I reduce the venous return, I reduce my preload. Once I reduce my preload, what's going to happen to my stroke volume? Stroke volume equals 2 end diastolic again minus end systolic volume. When I reduce my venous return, no blood is coming back, or I have a reduction in the amount of blood coming back to my heart. This will reduce my end diastolic volume. Here my end diastolic volume will be reduced. This reduction in the end diastolic volume will be accompanied by a reduction in stroke volume. How is this going to be used as a treatment for hypertension, do you think? When I reduce venous return. So you see on here, when you reduce venous return again, you're going to reduce end diastolic. When you reduce end diastolic, you're going to be reducing stroke volume. And once you reduce stroke volume, what's going to happen to the cardiac output? Again, what's cardiac output? Cardiac output is stroke volume times heart rate. So as you reduce stroke volume, cardiac output will be reduced. All right? And as we're going to mention in a minute, your blood pressure, mean arterial pressure, is equal to cardiac output times resistance, total peripheral resistance. All right? So mean arterial pressure is equal to cardiac output times resistance. So if I did have a reduction in my cardiac output, this means I will have reduction in my mean arterial pressure. Contractility is again the force of contraction of my cardiac muscle cells, and this is going to be determined by a given cardiac muscle length. And in a reduction in the contractility will directly reduce my stroke volume. An increase in the force of contraction will be increasing my stroke volume. What's afterload? Again, this is the amount of pressure that you need to overcome in order to allow the blood to be ejected. Any increase in the afterload, like in case of hypertension, this will result in an increase in the end systolic volume, and as a result of the increase in the end systolic volume, this is going to have a reduction. This is going to cause a reduction in my stroke volume. What term describes ventricular contraction? Ventricular contraction is going to be systolic. If you remember, systolic, like systolic blood pressure, systolic means it takes place during ventricular contraction. So ventricular contraction is referred to as systole or systole. All right, so please check the other videos that I've posted a few days ago on Canvas for the discussion on the homeostatic imbalance. So you can check this out in the other video lectures that I posted for you. Let's start now one of the most important topics in this chapter, which is going to be my blood pressure. A quick review of what we've discussed in class. Veins are going to be conducting the blood back to the heart. Arteries will conduct the blood away from the heart. The first set of arteries that we're going to have are the ones that will be coming directly out of the left ventricle. Those are going to be my elastic arteries. You remember the other names that we've used for the elastic arteries, those are my conducting vessels. Remember, why do I call them conducting vessels? Because they will allow the blood to keep moving during ventricular contraction and during ventricular relaxation by the recoil force. Muscular arteries, those are my distributing vessels. Those are the ones that will be regulating and allowing the blood to reach my organs. We did have the arterioles, and this is where I have the highest level of resistance, my arterioles. And I have my second type of vessels that we've seen in class. This was my capillaries. And capillaries are my exchange vessels. This is where I will be performing the gas exchange, allowing the nutrients to travel to the cells, allowing the waste products to return from the cells to the blood. Then I will be draining all those organs, like what we've seen with veins, and the tiniest veins are my postcapillary venules. Those postcapillary venules will drain into small veins and then large veins. We call the veins, those are my capacitance vessels. Why do we call them capacitance vessels? Because they have a large capacity. Most of the blood at any time of the cardiac cycle, at any moment of the cardiac cycle, your veins, your systemic veins you see on here and venules will have 60% of your blood volume. All right, so let's check on here. How do I distribute this cardiac output? If you remember, your cardiac output is equal to 5 liters during rest. It goes up to become 25 liters when you exercise. So maximum cardiac output and resting cardiac output. So what happens in here in terms of the blood distribution? So you see here at rest, I have almost 5 liters that will be pumped per minute. And during exercise, this goes up to almost 20 liters. You're not only increasing the cardiac output, the amount of blood that you pump per minute, you're also redistributing this amount of blood, this volume. So you see on here, for example, the brain is going to receive the same amount, so it did not increase. So here, 5 liters. Here I have 20 liters. So I'm expecting every single organ to get 4 times the amount of blood. But this didn't happen for my brain, for example. It did receive the same amount of blood. It doesn't require more blood supply during exercise. Compared to the heart, for example, more cardiac contraction, forceful contraction, faster contractions will be performed. So I need larger amounts of oxygen, larger amounts of nutrients to be supplied. So the amount of blood reaching my heart tissue will increase by 3 folds. So rather than receiving during rest 250 milliliters, it's going to receive 750 milliliters. If you notice on here, the organ that will be receiving the largest amount of blood here is going to be your skeletal muscles. Skeletal muscles, you see, I did start with 1 liter. It goes up to 12 liters. So it did increase 12 times the amount at rest. So you see on here, not every single organ will receive 4 times the blood supply during exercise. It's going to be widely variable. It's according to whether or not you are going to be using this organ during exercise. What allows you to increase or reduce the amount of blood reaching those different organs? First factor is going to be by increasing or reducing the diameter of the vascular arteries. So if I have my kidney, for example, here, during exercise, you don't want to give much blood to the kidney. You want the blood to be diverted to the skeletal muscles, let's say. So what I will do on here to reduce the amount of blood reaching my kidney, I will constrict the renal artery. And once you constrict the renal artery, less blood is going to be delivered to the kidney. Another factor that I will be using to regulate the amount of blood passing into a certain organ is by relaxing or constricting the precapillary sphincters. If you remember from our last discussion, we do have 2 types of capillaries. We do have the vascular shunts, which are direct connections between the arterioles and the venules. Those are not responsible for any exchange. And we did see the true capillaries, which are going to be responsible for the exchange to take place. If you remember, true capillaries are branching out from my meta-arterioles or my vascular shunts. So if you want the blood to be diverted away from the kidney, let's say, so what you're going to do, you're going to be constricting the precapillary sphincters. This increases the pressure here in my artery, in my precapillary arteriole. This increase in the resistance will be diverting the blood away from the organ. So it's going to travel to more important organs. So again, major factors that will affect the distribution of the blood. First thing is going to be by performing vasoconstriction or vasodilation of the distributing vessels, which are my muscular arteries. Another factor is by contracting or relaxing the precapillary sphincters. This what allowed me here to regulate the amount of blood reaching each of my organs. So you see on here, you don't want to digest when you exercise. So during rest, all your abdominal organs are receiving around 1.5 liters. Compared to when you exercise, your abdominal organs, your stomach, your large and small intestine, all this going to be receiving almost 600 milliliters. So almost 1/3 of the amount of blood that was delivered to your abdominal organs during rest will be delivered when you exercise. Major reduction on here because those organs are not going to be used. All right. Moving on to the venous system. I will carry the blood from the capillaries to the heart. by two types of vessels. I have the tiny veins, those are my venules, and the tiny veins will drain into larger veins, those are called veins. Venules will have a very similar structure to my capillaries. I am formed of one row of flat cells which are very porous. I have lots of pores like the fenestrated capillaries, if you remember from our last discussion. One row of flat cells, and those cells will have pores that will allow the exchange between the blood and your tissues. Those are actually large pores like the ones that we've seen with the sinusoid or the sinusoidal capillaries. They can even exchange white blood cells. So white blood cells can be moving through my venules. As they will become larger, they will start to gain more cell layers, and they might get one or two layers of smooth muscle cells as well. Those venules will later on drain into veins, and veins here are again my capacitance vessels. What I mean again by capacitance vessels? Capacitance vessels simply means that I am acting as a blood reservoir. At any point in your cardiac cycle, your systemic veins will have 60% of your blood volume. Compared to, you see on here, the heart, for example, only has 8% of the blood volume. The pulmonary vessels, your lungs, will have only 12%. Your arterioles and arteries will have around 15%. So most of the blood volume is going to be kept in your veins, in your systemic veins. Why do you think? Why the blood will be kept in your veins? Why it won't be kept in my arteries? Why it won't be kept in my heart? Why it won't be kept in my lungs? Why in my veins? Remember, two factors about the veins. Veins have large lumens compared to the arteries, which will have a much smaller diameter of the lumen. Also, veins will have thin walls compared to the arteries will have thick walls. Another thing that we need to put into consideration is that here in my arteries, I have a very high pressure. Why do you have a very high pressure in your arteries? Because simply you are receiving the blood from the heart directly, which applies a very high pressure. So once the blood moves out of the ventricle, it's going to be pumped at a very high pressure. And who's going to be receiving this blood at this high pressure is going to be your arteries. So the arteries always going to have high pressure. Compared to the veins, where do I get the blood in my veins? They are going to be coming from my, you remember on here from this diagram, the blood in your veins is going to be coming from the capillaries, then the venules, which will have a very low pressure. So the pressure in my veins is very low compared to my arteries. So which one the blood would like to stay in? If you have two job opportunities, two job offers, one with high pressure and the other one is going to be with low pressure, and they would pay you the same. Which one would you prefer? The one with high pressure or the one with low pressure? the one with low pressure. Same like the blood. The blood is always going to be trying to move from high pressure to low pressure. And where do I normally have a low pressure? In my veins. So two major factors here. First is going to be the structure of the vein itself. I have thin wall of the veins. I have large lumen. And I have a low pressure. Those are the factors that will make the veins to be the capacitance vessels. Again, what's capacitance vessels means? I am acting as a reservoir for the blood. Let's check here my systemic blood pressure. What is blood pressure? What do you think? Blood pressure is simply the pressure of the blood, but this is not enough here. What exactly of the blood will create this pressure? This is my blood vessel like this. Blood pressure, simply speaking, means the pressure of the blood flow. And what kind of pressure are you applying here by the blood flow? It's a pushing pressure that is applied due to the resistance created by the walls of the vessel. So you have what? First, you have blood flow. And against this blood flow, you're going to have friction with the wall of the vessel. This friction will create a resistance. Having flow against resistance, this what creates the pressure. So if you have a cup of coffee like this one, you just leave it on a table, or I leave it on my hand like this. Do I apply any pressure on my hand with this cup? Yes. It's trying to move down by its weight due to the gravity, and my hand here applies a resistance. Once you have force against resistance, this creates a pressure. Another example, if you are driving at a high speed and you open the window of your car, what would you feel? You're gonna feel that the air is popping your ears. Why? Because you have airflow and your eardrums are applying resistance against this flow. So what happens? The air is gonna apply pressure on your eardrums. When you close the window, you don't have this pressure anymore, because who's gonna relieve the pressure is you're gonna be the car window. All right, so again, simply speaking, what is pressure? Generally speaking, this is flow against resistance. If I have only flow, would I have a pressure? If you go in the space and you throw fluids, lots of fluid, you have very high flow in the space. Would this apply any pressure? No pressure. So in order for me to create a pressure, I need to have flow and resistance. What is the blood flow? Blood flow is going to be my cardiac output. This is the amount of blood that we pump per minute. And what is the resistance? Resistance is the resistance that is applied by all the arteries that we're going to be passing through, or the vessels that we're going to be passing through. What we are concerned with is going to be the arterial pressure. So we're going to consider only the resistance of the arteries. So again, what is blood pressure? Blood pressure means flow against resistance. If you don't have resistance, what happens to your blood pressure? No blood pressure. If you don't have flow, your heart is not pumping blood, no cardiac output. Would you have pressure? If you don't have flow, would you have pressure? No pressure. So again, what is pressure? This is flow against resistance. If I don't have any of them, I don't have this pressure. All right, keeping this in the back of your mind, let's check out here the difference in the pressure in the different locations of my vascular system. So starting first with my elastic arteries, the aorta and its major branches. I can see that the pressure when my ventricles contract is going to be around 120 millimeter mercury. And this is what we're going to call systolic pressure. What's systolic? Systolic means it's taking place during ventricular contraction. So I have blood flow against resistance, applying pressure on the wall of the vessel during ventricular contraction. This pressure I am detecting on the wall of the vessel is going to be my systolic blood pressure. And I have another pressure that will be detected. It's going to be your diastolic blood pressure. What is the diastolic blood pressure? This is the pressure of the blood applied on the wall of the vessel during ventricular relaxation. This is my diastolic blood pressure. So if I'm checking the diastolic blood pressure in the large arteries, aorta and its major branches, we can find that it's around 80 millimeter mercury. This is the amount of pressure that the blood flow will be putting on the wall of the vessels during ventricular relaxation. All right. If you notice on here, as I go away from the heart, what happens to the pressure? It's going to be declining. Both systolic and diastolic pressure are going to be declining, like this. In what type of vessels did you notice you've got a major drop in the pressure? So you see here, in my aorta and large arteries, it's almost constant. It's almost the same, 120 throughout my aorta and its major branch. Same. If you notice in the large arteries, you have some drop. So the systolic pressure did drop, let's say, from 120 to be 90, let's say. And from 80 to 78. This is in my arteries. But if you check the arterioles, what happened when the blood moves into my arterioles on here, in this part? It drops to almost from 90 all the way here, from 90 all the way to around 30 millimeter mercury. I've lost most of the pressure of the blood in my arterioles. Most of the pressure has been lost in the arterioles. Why? If you remember, what was the other names that we've given to the arterioles? Those are my resistance vessels. They apply the highest level of resistance. So if you see on here, you've got a pressure of 110, it drops, or 90 millimeter mercury, it drops all the way to 30 millimeter mercury. I have this major drop in the arterioles due to high resistance of those vessels. If you notice on here, the pressure in my capillaries will be between 30 millimeter mercury to 15 millimeter mercury. And this is going to be enough for the capillaries. You don't need a higher pressure in the capillaries. What's going to happen if you did increase the blood pressure in your capillaries? They will rupture. If you remember, capillaries are formed of one row of flat cells. That's it. Why don't you increase the pressure to allow more exchange to take place? Simply because you don't need. The exchange that you want is already taking place. If you remember, I have 3 types of capillaries. I have my continuous capillaries, which are going to be located in the skin, brain, and muscles, which allow a minimal amount of permeability. We've seen another type of capillaries, which are going to be my fenestrated capillaries, which has pores, and those were located in the small intestines, in the endocrine glands, and in the kidneys, and those will allow a higher level of permeability. So I change the structure of the capillary rather than increasing its pressure. You don't want to increase the pressure, because if you did increase the blood pressure in the capillaries, they will rupture. If you notice on here, what forms your pulse? What is my pulse pressure? If you feel the pulse, what do you actually feel? I feel difference between the systolic and the diastolic blood pressure. I don't feel the blood pressure itself. I feel the difference between systolic and the diastolic pressures. Mean arterial pressure is going to be my diastolic pressure plus 1/3 of the pulse pressure. Also, another formula that we're going to be using is going to be cardiac output times total peripheral resistance. Capillary blood pressure, as we've mentioned, is going to be low. It runs between 15 to 35 millimeter mercury. You don't need a high blood pressure, because this high blood pressure will result in rupture of those capillaries. Most of the capillaries are very permeable, so you don't need to apply a higher pressure to increase the permeability. Venous blood pressure, it runs around 15 millimeter mercury. Here comes a question. How do I get the blood back to the heart if my veins have only a pressure of 15 millimeter mercury? This is a very low pressure. So if you are looking at leg veins, for example, if this is my leg here, in order for this blood to move from my leg veins all the way up, it's gonna need to move against the gravity. So 15 millimeter mercury is gonna be too low to move this blood all the way up to your heart. So how do I get this blood back to my heart if my veins have very low pressure? First thing is gonna be the presence of the valves. Veins have valves. And what is the function of the valves? The valves will allow the blood to travel up. Once it tries to return back down, it's going to be prevented. So the valves in the veins will allow this unidirectional flow of the blood up back to the heart. But this didn't tell you that how you are pushing the blood. You're saying that the presence of the valves will not allow the blood to return, but you didn't tell me how the blood is going to be moving and why the blood moves up in the first place. You're saying here valves will prevent the return, but you didn't tell me how it's going to move in the first place. The first factor that will enhance the venous return is going to be the muscular pump. Your leg muscles here, when they contract, they will be squeezing your leg veins. And once I squeeze the leg veins, what's going to happen to the diameter of those veins? You see on here, after contraction, squeezed veins, so the diameter of the vein is going to be reduced. What was the relationship between volume and pressure? If I have reduction in my volume, what happens to the pressure? Can you remind me? It goes up or down? Yes, exactly, it goes up. I have an increase in my pressure of the blood in the veins just due to the external muscular contraction. This allows the blood to travel up into my veins, and due to the presence of the valves, the blood will not return to move down. All right? Another factor on here is going to be the respiratory pump. If you remember, the lungs are located in the chest, and the chest is going to be formed, chest wall is going to be formed by the ribs and the intercostal muscles. If you remember, the lungs are going to be covered by a membrane. This membrane is called my pleura. The pleural membrane is going to be formed of two layers. A layer that will be in direct contact with my lungs. This is going to be my visceral layer. And another layer that will be lining my chest wall. This is going to be my parietal layer. So you have two layers of the pleura located between your lungs and your chest wall. Your lungs always have tendency to collapse like a balloon. I have lots of elastic tissue. When you inflate a balloon, the balloon will collapse. Always the lungs will be trying to recoil, to collapse. Your chest, on the other hand, it has tendency to expand, to go out. So if my chest wall has tendency to expand and my lungs have tendency to recoil, what's going to happen between the two layers of the pleura? I have two layers on here. One is attached to the lung. One is attached to the chest wall. This is my visceral layer. This is my parietal layer. The chest wall is moving out. The lungs are going to be trying to move in. So what happens to the space between the two layers of the pleura? The intrapleural cavity, this space is going to be increased. The size of this cavity should be increased. And can you remind me, what is the relationship between volume and pressure again? When I increase the volume of the pleural cavity, This will be accompanied by a drop in its pressure. See on here, I have one visceral layer is going to be trying to be moving with my lung, and I have the other layer is going to be trying to move out with my chest wall. Two layers are moving away from each other. So the volume of the pleural cavity is going to be increasing, and as a result, this will be accompanied by a reduction in its pressure. This tells you what? This tells you that in your chest wall, when you breathe, just breathing, when I inhale air, what happens to my lungs' tendency to recoil? The tendency of the lungs to recoil will be increased. And as a result, increase in the volume accompanied by reduction in the pressure. I am creating a negative pressure within my pleural cavity. This is a suction force in the chest. So what happens in here, I am gonna be creating a negative pressure in the chest that pulls the blood up from my veins to the chest. So two pumps that we've seen so far. First pump is gonna be the muscular pump. This is gonna be due to the contraction of the skeletal muscles of the legs. When you contract the leg muscles, they will squeeze the veins, creating a higher pressure in your veins. When you breathe, this increases your lungs' tendency to recoil, and this will reduce the intrathoracic pressure. This reduction in the intrathoracic pressure is going to be pulling the blood up to my heart from my leg veins. Another factor that will affect the venous return on here is going to be the vasoconstriction of the veins. And this is going to be mediated by the sympathetic nervous system. So sympathetic nervous system increases the contraction of the smooth muscles of your veins. This will reduce their diameter, increasing their pressure. All right, so again, three factors on here that will enhance the venous return. Those are my respiratory pump, my muscular pump, and the vasoconstriction of the veins. This is going to be under the effect of the sympathetic nervous system. Any questions? Questions so far? Questions? So where is blood pressure highest? Where do you think? Is it in your capillaries, your veins, your arterioles? This is going to be in your elastic arteries. If you remember, the closer you are located to the ventricle, the higher the pressure will be. So the first vessels that will be receiving the blood from your ventricles are going to be the elastic arteries. So they will be the ones with the highest blood pressure. Why do I need to have blood pressure? And how do I maintain it? First thing that will create a pressure, again, as we mentioned earlier, is going to be flow. And the flow in here in terms of blood pressure is going to be my cardiac output. Also, another factor that will need to be present is going to be your peripheral resistance. A third factor that will directly affect your blood pressure is going to be the blood volume. So 3 factors that we need to be aware of in terms of maintaining blood pressure are going to be cardiac output, peripheral resistance, and blood volume. How do I maintain my blood pressure? First, I have neurological control of the blood pressure. This is going to be mediated by 2 forms of receptors. First are going to be my baroreceptors, which are located in the large vessels. And the baroreceptors are actually going to be responsible to detect the degree of stretch of your arteries. So let's say if my baroreceptors did detect an increase in the degree of stretch, I have increased stretch. So this means what in terms of blood pressure? Having more stretch to the wall of the vessel means I have high blood pressure. So those baroreceptors will send out signals to my nervous system. My nervous system will respond by performing, what do you think? If I have here cardiac output times peripheral resistance equals my mean arterial pressure. So how the nervous system is going to be responding to an increased blood pressure? It will be trying to reduce resistance. And how would I reduce the resistance in my arteries? By performing vasodilation, by dilating my arteries. So you see on here, response is going to be vasodilation. This vasodilation will directly reduce your peripheral resistance, and as a result, you're going to have a reduction in the mean arterial pressure, getting your blood pressure back to normal. Another neurological control of the blood pressure is going to be mediated by chemo receptors. And the most important chemical factor that will trigger the activity of the chemoreceptors is going to be carbon dioxide levels. This is the most important chemical factor that will give you an idea, give you an impression on the blood pressure. If, let's say, I've got high carbon dioxide level. If I have high carbon dioxide level, it means I have low blood pressure. Why? Because simply I need to have enough pressure. I need to have enough pressure in order for the blood to be delivered to my lungs, for the lungs to perform gas exchange. So if I don't have a gas exchange, this means I have a reduction in my blood pressure. It's below normal. So if you did have an increase in the carbon dioxide level, this gives you an idea about the state of your blood pressure, which means, in other words, a reduction in the blood pressure. So I will respond in the same exact way like the baroreceptors. You send out signals to the brain, to the nervous system. The nervous system will respond by performing this time vasoconstriction instead of the vasodilation. When you vasoconstrict, what's going to be its effect on your resistance? You notice on here, vasoconstriction will be increasing my peripheral resistance. And once I increase the peripheral resistance, I will have an increase in my mean arterial pressure. And this will correct the reduction that I've got. Moving on to endocrine. System regulation of the blood pressure. We have many hormones or hormonal regulation. Many hormones that will participate in regulating your blood pressure. First one is going to be my angiotensin. So from its name, angio is related to the blood vessel, and tensin means I am performing tension of the wall of this vessel. So angiotensin, this is going to be responsible to constrict the blood vessel. And once I constrict the blood vessel, what's going to happen to my blood pressure? I'm performing vasoconstriction. So again, what is the relationship between vasoconstriction and your blood pressure? Blood pressure equals to cardiac output times peripheral resistance. If I did vasoconstrict, this will directly increase my peripheral resistance. Once I increase the peripheral resistance, the pressure will go up. So it's like pressing on the end of the hose when you are watering your yard. When you reduce the diameter of the hose, what happens to the pressure of the water? The pressure of the water is going to be increased. The same concept on here. So when I constrict my vessel, this will directly increase resistance, and once I increase the resistance, I will have an increase in the mean arterial pressure, angiotensin. Another hormone that will be affecting my blood pressure is going to be anti-diuretic hormone. From its name, what's going to be my function? Anti means I am preventing, and I'm preventing diuresis. Diuresis means water release in the urine. So I am a hormone that prevents the water release in the urine. So where do a person normally gets the urine from? So let's go. If this is the urinary tract, where do you normally get the urine from? Where is the urine is coming from? It's coming from filtration of your blood. So I would be pulling water from the blood to be released out in the urine. So if I'm telling you that this ADH is a hormone that's going to be preventing the loss of water in the urine. So this tells you what? This tells me that the water gonna remain in my blood vessels. So the water that I'm drinking is not going to be released out in the urine. It's going to be kept as blood volume. So antidiuretic hormone, when it prevents water loss in the urine, it's going to be increasing my blood volume. Once I increase blood volume, what's going to happen to the pressure? If you have a bottle with 2 liters of water and another bottle with only 200 milliliters of water, and you leave them on a table, which one applies more pressure on this table? The one with 2 liters applies more pressure than the one with 200 milliliters. So you see on here, the higher the volume, the higher the pressure. So you see on here, antidiuretic hormone, when it prevents the water loss in the urine, it's going to be directly increasing the blood volume, and increase in blood volume means increase in the mean arterial pressure, increase in the blood pressure. Moving on to another hormone that will also going to be affecting my blood pressure, and this is going to be my catecholamines, or epinephrine and norepinephrine. You remember, epinephrine and norepinephrine are going to be released from the adrenal medulla of the adrenal gland under the effect of the sympathetic nervous system in response to a fight or a flight. All right, in a flight or flight situation. Sympathetic nervous system going to be activating the adrenal medulla, releasing the epinephrine and norepinephrine in the bloodstream. The function here of the catecholamines, epinephrine and norepinephrine, is going to be to perform vasoconstriction. And if you remember, vasoconstriction means I have an increase in my peripheral resistance. I have more resistance facing my blood flow. Another thing that the catecholamine is going to be acting on is going to be on the heart. It's going to be increasing the contractility and the heart rate. If you remember, when you increase contractility, what's going to happen? You're going to have an increase in stroke volume. If I have an increase in stroke volume, an increase in the heart rate, this will result in an increase in your cardiac output. Exactly. So you see on here, catecholamines, epinephrine and norepinephrine, are increasing my total peripheral resistance by performing vasoconstriction. I am increasing my cardiac outputs by increasing heart rate and stroke volume. So you've got an increase in every single aspect here of the equation. Cardiac output will be increased, your peripheral resistance is going to be increased, and of course, as a result, you're going to have a major increase in your mean arterial pressure. All right? Another hormone that we're going to be discussing in more details in the next chapter, in the kidney chapters. This is my atrial natriuretic peptide. Just a brief introduction about this hormone. It's going to be released from your atrium. That's why it's called atrial. And its chemical structure, it has a protein structure. So we're going to call it peptide. It's a small protein. So it's a peptide released from the atrium. And it's natriuretic. Retic. Okay, double check the spelling out here. All right, so what does natriuretic means? So if you know here, carbon is the atomic symbol for the C here is the atomic symbol for the carbon. The H is the atomic symbol for hydrogen. Iron, it's Fe. So where did we get those atomic symbols? They are the first letter or two letters of my element name. But let's say iron, for example, doesn't start with Fe. So actually it's ferrous. I am the first letter or two letters of the Latin origin, not the English name of the element. All right, so same concept for sodium. Sodium is Na. What's Na? It's natrium. So you see on here, I am a hormone which is natriuretic. Uretic means I am released in the urine. And what are you releasing in the urine is going to be natrium. So you see on here, one of the effects of my atrial natriuretic peptide is to release the sodium in the urine. You see on here, this is going to be my sodium. It's going to be traveling from the blood to the urine. Who's going to be following any sodium movement? Any solid movement will result in net water movement. Water here will follow the sodium by osmosis. So if I'm releasing the sodium out in the urine, water follows by osmosis. What's osmosis? If you remember, osmosis is going to be the movement of water from low sodium content to higher sodium content. Exactly. This is what we've called osmosis. So you see on here, if I am releasing the sodium out in the urine, water gonna be released out by osmosis. And as a result, what's gonna happen to your blood volume? If I'm releasing sodium in the urine, it's gonna be followed by water. So I will have a drop in my blood volume because you're losing water out in the urine by osmosis. And reduction in blood volume, what do you think is going to be its effect on your blood pressure? If I have less water, I have reduced pressure. Exactly. Reduction in my blood pressure. All right. So this reduction in the blood pressure is what the heart is willing to do. I want to check here something that makes perfect sense. What do you think is going to be the organ that hates high blood pressure and is going to be trying all the time to reduce it? Is going to be the heart. The heart hates high blood pressure. Why? If you remember, as we've mentioned earlier today,
the higher the pressure, the more it has to work.
The higher pressure that I need to overcome, the more work the heart is going to be exerting. Exactly. Remember, in order for me to overcome the arterial pressure, the heart needs to increase heart rate and contractility because of an increase in the arterial pressure. Afterload, here, this is the factors that we've mentioned. Increased afterload means increased pressure that you need to overcome to eject the blood out, which will put more load on your heart. That's why heart hates high blood pressure. Who hates low blood pressure is going to be your kidney. Kidneys hate low blood pressure. Why? Because the function of the kidney is to allow the filtration of the blood. If this is my blood vessel on here, this is my kidney tubule. In order for the fluids, solutes to travel from my blood to my kidney tubules, I need to have high pressure of the blood for this filtration to take place. If no enough pressure means no filtration, means no kidney function. So you will notice on here the hormones that will be released to increase the blood pressure, like for example, the angiotensin is going to be activated by another hormone that we're going to see in the kidney, called the renin. Renin is a hormone that will be released from the kidneys that activates the angiotensin for it to perform its different functions. Also, angiotensin is the one that triggers the release of ADH. You see, what initiates this hormonal control of the low blood pressure is going to be your kidneys. Kidneys hate low blood pressure. On the other hand, atrial natriuretic peptide is going to be lowering down the blood pressure because makes perfect sense on here because the heart hates high arterial pressure. All right, moving on to why do we need to have normal blood pressure? Why I don't keep it so low? Because simply you need this pressure, like what we did with the hose, in order for us to water all the yard. I need to have enough pressure of the water to reach all the way to the back of the yard. So the same concept on here. If I don't have enough pressure of the blood flow, the blood will not be able to get into my organs. No exchange will be taking place. The ability of the blood to reach my tissues, this is what we're going to call my tissue perfusion. And why do I need to have tissue perfusion? To allow delivery of the oxygen, to allow the delivery of the nutrients, to remove the waste from your tissues, to carry the waste away from the tissue, to perform gas exchange, to get the oxygen, to release the carbon dioxide in the lungs, to allow the absorption of the nutrients in your digestive system. If I don't have enough blood pressure, the blood is not reaching my small intestine, there is no way that the nutrients will be passing from the small intestine to my blood. So no absorption is going to be taking place if I don't have enough tissue perfusion. Another thing that I needed to have enough blood pressure is to allow the filtration of the blood in the kidneys. If I don't have enough tissue perfusion, the blood will not get filtered in the kidneys. All right? We've discussed the generalized regulation, nervous regulation, the endocrine regulation of my blood pressure. But I have another type of regulation which is going to be more concerned with the amount of blood reaching a specific organ. It's more localized regulation, or what we call auto regulation. It's not generalized. It's not going to be taking place all over the body. It's going to be taking place at one specific site. It's going to be regulating itself. So the blood vessels will respond to increase or decrease in stretch on their own. Also, they will respond to metabolic changes on their own. So let's say on here, metabolic controls. If I have my organ here, this is my kidney, let's say, and this is a blood vessel that will be bringing the blood to my kidney. I did detect in the blood reaching my kidney, I have decline in the oxygen levels. This tells me what? If I have decline in the oxygen levels, this means I didn't have enough gas exchange. This means I don't have enough tissue perfusion, which means I have low blood pressure or low pressure of blood. This is going to be also prominent in more, let's say, the brain on here. If I detected low oxygen levels, this means I have low tissue perfusion. So how do you think this vessel will be responding? If I did identify that I have low tissue perfusion at this specific site in the body, would you like to dilate the vessel or constrict the vessel? If you don't have enough blood reaching this organ.
Dilate, right?
Dilate. It looks as if it was opposing what we mentioned earlier. We mentioned earlier, if you want to increase the pressure, you constrict, right? But this is in terms of generalized regulation. Here we're looking at more specific site. I have reduction in the tissue perfusion in this specific vessel. So if I did constrict this vessel, no blood gonna be reaching this organ anymore, because I have very small amounts of blood that are reaching the organ. If you did perform more vascular constriction at the organ level, it will completely block the blood delivery. So I will respond by performing vasodilation. This is how the autoregulation is going to be different from the neural and hormonal regulation. So you see on here, if I have low perfusion, you dilate the vessel. Same concept on here when we're dealing with the myogenic controls. If I have an increase in the degree of stretch, let's say I am at the level of the kidney as well. This is my kidney on here. I have low tissue perfusion, and this is going to be detected by reduction in the degree of stretch of those vessels. How the vessel will respond on its own if it doesn't have enough stretch. I have reduction in the degree of stretch of the wall of the vessel. The vessel will be performing vasodilation. It will dilate, and this will directly increase the amount of blood reaching this specific site. So if I have reduction in terms of tissue perfusion, in a localized site, the vessel at this site will be dilated. If I do have increase in the degree of stretch to the blood vessel going to a specific organ, this means what? This means I am getting more blood than what I need. So how do you think I will need to respond as a vessel? I'm responding only as a vessel. I have an auto-regulation. Only this vessel is going to be responding. It's not a generalized vasoconstriction or dilation. You see on here? So what do you think?
It's going to want to constrict, right?
Constrict, exactly. So you're going to need to perform vasoconstriction here of this specific vessel to reduce the amount of blood reaching this specific site. Because if you did not, you're gonna keep getting lots of blood to those tissues. This will result in rupture of the capillaries. All right. So you want to deliver enough blood by maintaining enough tissue perfusion, but in the same time, you don't want to get too much blood reaching your capillaries because this might result in rupture of those capillaries. All right, this is the difference here between the generalized regulation and the auto-regulation. Again, generalized regulation, I am affecting all the arterioles of the body. If my nervous system, if my sympathetic nervous system did detect that I have low blood pressure, all my blood vessels going to be constricting under the effect of the sympathetic nervous system. And this constriction of the blood vessels will increase the peripheral resistance, increasing your blood pressure. This is generalized regulation. If my kidney did detect that I have low blood pressure, it's going to be responding by releasing hormones, and those hormones will be constricting all the vessels, retaining water. This will directly increase your blood pressure. But here at a localized site, only at organ levels, I don't have a generalized problem with my blood pressure, or I don't have to. Only at an organ level. The vessels themselves will be regulating their diameter according to metabolic factors and myogenic. Metabolic factors like the presence of vasodilators like nitric oxide that will dilate the blood vessel, like the levels of oxygen, like the amount of potassium, adenosine, prostaglandins, all those are intracellular structures. If you remember, you don't have much potassium outside of the cell. You don't have much adenosine, like the ATP outside of the cell. You don't have ATP moving outside of the cells. You need ATP inside the cells to conduct the cellular activity. So if you find adenosine outside, if you find potassium outside, if you find lots of prostaglandins, which are actually inflammatory mediators, all this means I have cellular destruction. The cells have ruptured and they did release their contents to the outside. So rupture of the cells, I have tissue death. This directly means no enough blood reaching those cells. That's why they are dead. So having too much hydrogen, too much potassium, too much adenosine, too much prostaglandins than normal. This means I don't get enough blood. This means I have low tissue perfusion. And if I have low tissue perfusion, how would I respond? I will respond by performing, again, vasodilation to increase the amount of blood reaching this specific site. Compared to the myogenic control, again, this is going to be according to the degree of stretch that you're going to be detecting. So if I have passive stretch, increase in the degree of stretch of the wall of the vessel, this means I am getting more than what I need. So I need to reduce the amount of blood getting into my tissue. So how to reduce the amount of blood? By performing constriction of this specific vessel. If I am detecting a reduction in the degree of stretch of the wall of the vessel, this means I am not receiving enough blood, no enough tissue perfusion, and I want to increase the diameter of the blood vessel to conduct more blood to this specific site. All right? This completes our discussion here on the blood pressure regulation and cardiac outputs. So let's answer this question on here. How do we move more blood to the skeletal muscles when we do exercise? Do we open precapillary sphincters of the skeletal muscles? Do we close precapillary sphincters in less important organs? Or we gotta do both? Yes, exactly. You remember, capillaries are gonna be either vascular shunts or my true capillaries. Exactly. So you're gonna have here, this is my post-capillary venule, pre-capillary arteriole. They are directly connected with mid-arteriole or vascular shunt. It's a direct that doesn't allow any exchange to take place. But what branches out here of the vascular shunt is going to be my true capillaries that will form the capillary beds. And remember, the base of the true capillary is going to be guarded by a sphincter, a muscle on here. So if I don't want to allow more blood to pass into a specific organ, let's say my stomach when I exercise, I don't want blood to be delivered to my stomach, so I will be contracting my precapillary sphincter, preventing the blood to flow in here to my stomach, creating high resistance against the blood flow into my stomach. This will directly shift the blood away from my stomach. But what's going to happen in my skeletal muscles? I will be dilating those precapillary sphincter. I will open them, and this will allow the blood, more blood to travel to my skeletal muscle tissue through the true capillaries. All right? Any of you would like to ask me any question before we